Hello, everyone, and welcome to our module on neuromuscular junction disorders. Okay, before we get into specific neuromuscular junction disorders, let's review how the neuromuscular junction itself works. So, the neuromuscular junction is made up of two major components. One is a nerve terminal, it's the end of a neuron, that's what I'm drawing right here. Then you have a synapse, and on the other side of the synapse, you have a muscle fiber. The way this works is depolarization travels down the neuron, and when it reaches the nerve terminal, calcium comes inside the neuron. So that's a key event at the neuromuscular junction, the entry of calcium through so-called voltage-gated calcium channels. And they get this name because they're calcium channels that open when the voltage changes in the neuron, meaning when it depolarizes. Once the calcium comes in, that's going to trigger the release of acetylcholine, which is a neurotransmitter, which is going to go and bind to receptors on the muscle fiber, and that's going to cause the muscle fiber to depolarize and contract. And then the final event that's important at the neuromuscular junction is the acetylcholine is not going to just sit around forever in the synapse. It's going to get broken down. And the enzyme that does that is called acetylcholinesterase. And so I've summarized all these points here. Pre-synapse, you have the nerve terminal, depolarizes and calcium comes in. That leads to the release of acetylcholine. Post-synapse, you have the motor end plate. That's the portion of the muscle fiber near the nerve terminal. Acetylcholine binds to nicotinic receptors, and that leads to muscle depolarization and contraction. And then finally, acetylcholinesterase breaks down the acetylcholine in the neuromuscular junction. And so all these events are going to be important as we talk about neuromuscular junction disorders in the next couple of slides. So we'll start by talking about myasthenia gravis, which is an autoimmune disease, and it's the most common neuromuscular junction disorder. And the cause of myasthenia gravis is acetylcholine receptor antibodies. So patients with this condition produce antibodies that bind to their own nicotinic acetylcholine receptors found on the motor end plate of muscle fibers. And those antibodies compete with acetylcholine for receptor binding, making it harder for acetylcholine to bind and cause a muscle contraction. And that leads to weakness, which we'll talk about in a second. And these antibodies are important as a cause of myasthenia gravis. They're also used for diagnosis, which we'll talk about later. And myasthenia gravis, because it involves the production of antibodies that attack our own tissues, it's an example of a type 2 hypersensitivity reaction. And I talk about these reactions in detail in the videos in the immunology section. And if you look over at this cartoon on the slide here, this will just give you a very clear picture of what's going on with myasthenia gravis. So normally the acetylcholine receptor binds to acetylcholine molecules, which are these little blue things shown here. But in patients with myasthenia gravis, you have antibodies floating around, and those antibodies bind and block the receptor, and therefore acetylcholine cannot bind, and that's going to lead to neuromuscular weakness. Myasthenia gravis is defined by a phenomenon known as muscle fatigability. So let's talk about what we mean by this. So if you depolarize a nerve terminal and try to contract a muscle fiber over and over again, there's actually a slight decrease in the amount of acetylcholine that's released with each successive stimulation of the muscle fiber. This happens because the nerve terminal just can't reaccumulate as much acetylcholine when you keep depolarizing it over and over and over again. So there's a slight drop off with successive stimulations of how much acetylcholine is released. Now, if you have a healthy, normal neuromuscular junction, there's no major effect of this phenomenon of less acetylcholine being released. However, in patients with myasthenia gravis, they have fewer acetylcholine receptors available because many of them are being blocked by those antibodies. So what happens in myasthenia gravis is the first stimulus leads to the strongest muscle contraction, strongest response because you get the most acetylcholine release. But then with successive stimulations, the muscles weaken and you get less and less contraction. This is called muscle fatigability, classic feature of myasthenia gravis. And the way it's depicted visually, if you do specialized nerve testing, is shown right here on the slide. So the first depolarization leads to the largest response, but then additional stimulations of the nerve terminal lead to weaker responses. This is muscle fatigability, classic finding in myasthenia gravis. Okay, so now let's talk about what happens in specific muscles throughout the body because of muscle fatigability in myasthenia gravis. And we'll start by focusing on the eyes. So two classic features of myasthenia gravis, this is often how the condition presents, are diplopia and ptosis. Diplopia means double vision, ptosis means drooping of the eyelid. Double vision occurs because the extraocular muscles become weak, and so the eyes get misaligned, and that leads to blurry vision. And the drooping of the eyelid occurs because the levator palpebrae superioris, which is one of the muscles that raises the eyelid, becomes weak, and that leads to ptosis, which is shown here in this picture. And you should know that eye problems like diplopia and ptosis are the most common initial presentation of myasthenia gravis. In a board question, someone with a new diagnosis is almost certainly going to have these clinical features. Less commonly than eye problems, patients with myasthenia gravis develop so-called bulbar muscle involvement. So the bulbar muscles are muscles of the face and the mouth that have nerves that arise in the medulla, which is also called the bulb of the brainstem. So basically, when we say bulbar muscle weakness, we mean cranial nerve weakness involving the head and neck. Specifically, what patients with myasthenia gravis often present with are dysphagia, so difficulty swallowing, and also difficulty chewing. And these types of bulbar muscle weakness problems are the presenting feature in about 15% of patients with MG. Proximal muscle weakness is something that you can see in myasthenia gravis, but it's relatively rare. It only happens in about 5% of patients. So proximal muscle weakness means weakness of muscles involving the shoulders and the legs. So patients who have proximal muscle weakness classically complain of difficulty rising from a chair because that requires you to use proximal muscles around the hip. And as we'll see later in this video, proximal muscle weakness is much more common in LEMS, which is another neuromuscular junction disorder. It's much less common in myasthenia gravis. And then the feared complication of myasthenia gravis is that it can involve the respiratory muscles. This is rare, but it's a life-threatening complication of the disorder. And the time where you most often see respiratory muscle weakness in myasthenia gravis is when the patient has a sudden myasthenia crisis, meaning an abrupt worsening of symptoms. We're going to talk about this shortly, but patients with myasthenia gravis sometimes experience an abrupt, sudden onset worsening of symptoms after surgery or when they have an infection or if their meds are tapered, and this is the kind of thing that can lead to respiratory muscle weakness. Importantly, for your step 1 exam, you want to remember that any type of respiratory muscle weakness is going to lead to restrictive lung findings, which I talk about in detail in the pulmonary section. But in restrictive lung conditions, you have a fall in the TLC, the vital capacity, the FEV, the FRC, all the volumes and capacities listed here. And this is something that's likely to come up on your exams. It's seen in any person who has respiratory failure from respiratory muscle weakness, including patients with MG. It's super high yield to know that the deep tendon reflexes are intact in myasthenia gravis. That includes the patellar reflex, which is shown being tested here. The reason this is the case is because the reflex arc, when you perform reflex testing, generates one brief, strong burst of acetylcholine, and that's usually enough to generate a muscle contraction and a response, even though there's a decreased number of receptors overall. Basically, testing DTRs doesn't bring out fatigability because you're not testing the contraction over and over again. And usually you get one good contraction, and that leads to a normal finding when you test the DTRs. There's 2 tests that are used to diagnose myasthenia gravis, and hopefully they make sense to you after everything we've been through so far. So one is a blood test to detect acetylcholine receptor antibodies, and the other is electromyography, which is a test where you repetitively stimulate a nerve and you look at the response to that repetitive stimulation. And what you will see is a progressive reduction in the muscle action potential, and that's what's shown here in this diagram that we saw earlier in the video. Okay, I mentioned this earlier, but patients who have myasthenia gravis are vulnerable to myasthenia crises, which refers to an acute worsening of their symptoms. There are many triggers that have been described as bringing on a myasthenia crisis, but some of the important ones are listed on this slide. So first of all, infection can do this. A patient with myasthenia gravis who gets pneumonia can have the pneumonia stir up the immune system, and that can lead to the production of more antibodies and more weakness. Myasthenia crises have been described after surgery. They've been described in women who are pregnant or just gave birth. They're also a classic complication of trying to taper the meds in someone who is on chronic medication for myasthenia gravis. As I mentioned earlier, this can be a life-threatening condition if it leads to respiratory muscle weakness. And so some of the treatments that can be used are the same treatments we use for Guillain-Barré, which I talk about in another video, but those are things like plasma exchange and IVIG. When a person who has myasthenia gravis presents with an abrupt worsening of symptoms, the diagnosis is almost always myasthenia crisis. However, you do have to consider that it is possible that they could instead have a cholinergic crisis, which is another phenomenon that can occur in myasthenia patients that also leads to an acute worsening of symptoms. So a cholinergic crisis is a very rare cause of increased weakness in patients with myasthenia gravis, and it's caused because we treat these patients with cholinesterase inhibitors, which I'm going to talk about in a minute. These drugs boost the levels of acetylcholine at the neuromuscular junction, and that's good for myasthenia gravis. However, if the patient is overdosed on cholinesterase inhibitors, they can get so much acetylcholine at the neuromuscular junctions that they get a cholinergic crisis, which also causes weakness similar to a myasthenia crisis. The reason you have to distinguish these 2 conditions from one another is that they have different treatments. The treatment for a myasthenia crisis, as I talked about earlier, is plasma exchange and IVIG, whereas the treatment for a cholinergic crisis is to stop the cholinesterase inhibitor meds and administer drugs that activate muscarinic receptors, drugs like atropine. So if you look at this table I made for you on the slide, it shows the difference between a myasthenic crisis and a cholinergic crisis. And remember what I said, in actual practice, when patients with myasthenia gravis develop acute onset of weakness, it's almost always a myasthenic crisis. But especially for board exams, you need to be aware of the phenomenon of a cholinergic crisis triggered by the meds used to treat myasthenia. So in a cholinergic crisis, there's too much acetylcholine activity. The activity is too high, and this is going to activate things outside the neuromuscular junction. It's going to activate acetylcholine receptors throughout the parasympathetic nervous system, so the pupils will become constricted, that's meiosis, and you will get muscarinic symptoms like diarrhea and salivation. In contrast, when the patient is having a myasthenic crisis, the pupils are normal and you don't have any muscarinic symptoms, and this is really how you distinguish the two clinical syndromes from one another. Okay, let's talk about the treatment of myasthenia gravis. So patients with this condition usually take two medications. One is an immunosuppressant. Usually it's a corticosteroid like prednisone, but sometimes it's an alternative drug like azathioprine. These drugs decrease the production of antibodies. The other type of drug these patients take is an acetylcholinesterase inhibitor. So we talked at the beginning of this video about how acetylcholinesterase breaks down acetylcholine in the neuromuscular junction. So if you give an inhibitor of the enzyme acetylcholinesterase, you will get increased acetylcholine levels at the neuromuscular junction, and that will improve weakness. These are the three acetylcholinesterase inhibitor drugs used to treat myasthenia gravis. Edrophonium is really not used anymore. It has a very short half-life. It used to be given at the bedside sometimes as a diagnostic test for myasthenia gravis. The drug most commonly used is pyridostigmine because it has the longest half-life, although neostigmine is also sometimes used. But any of these three drugs shown on the table here are going to decrease the metabolism of acetylcholine at the neuromuscular junction and boost acetylcholine levels, and this is going to improve weakness. The downside of these drugs, which I talk about in detail in other videos, is that they are going to activate acetylcholine receptors throughout the body that are part of the parasympathetic nervous system. So in the gut, this will increase GI motility and patients can get cramping and diarrhea. In the mouth, this can activate salivary glands, so patients can have salivation from these drugs. And in the heart, this can decrease the heart rate and lead to bradycardia and sometimes dizziness. Super high yield to know that most patients with myasthenia gravis have an abnormal thymus. About 65% of patients have hyperplasia of the thymus, and 15% actually have a thymoma, a tumor of the thymus. And this is important because myasthenia gravis sometimes resolves with thymectomy, so removing the thymus can be a curative procedure. And that's because within the thymus, you find B cells that produce those anti-acetylcholine receptor antibodies that are causing myasthenia gravis. And so if you take out the thymus gland, you remove these B cells, and you can sometimes resolve myasthenia gravis. So the way this often comes up in a board question is a patient who has a new diagnosis of myasthenia gravis, what is the next best test? The answer could be imaging of the mediastinum, like a CT scan or an MRI. And the reason this is the next best test sometimes is because you want to image the thymus and see if it's abnormal. A huge part of living with myasthenia gravis for patients who have this condition is avoiding medications that can make their condition worse. The list of drugs that can potentially worsen neuromuscular weakness in myasthenia gravis is enormous. You can look it up online and read through it if you wish. But I've listed some of the important drugs to be familiar with on this slide. A huge group of drugs that patients with myasthenia have to avoid are the aminoglycoside antibiotics, including all these drugs I've listed right here. One of the effects of aminoglycosides is that they decrease release of acetylcholine at the nerve terminal before the synapse. So obviously in patients who have myasthenia gravis, this is going to make their muscle weakness worse, and this can trigger a myasthenia crisis. There are some other antibiotics that patients with MG need to avoid. These are things like fluoroquinolones and macrolides. Beta blockers need to be avoided, and any neuromuscular blocking agent or paralytic, like all these drugs here, which I talk about in the anesthesia section, they can be very dangerous for patients with myasthenia gravis. Okay, moving on, let's talk about our second neuromuscular junction disorder for this video, and that's the Lambert-Eaton myasthenic syndrome, also called LEMS. This is a very rare disorder of the neuromuscular junction. It's much less common than myasthenia gravis. And this is a paraneoplastic syndrome. It's associated most strongly with small cell lung cancer. What happens in LEMS is that patients develop antibodies to presynaptic calcium channels. We talked about that earlier, that when the nerve depolarizes, and the wave of depolarization reaches the nerve terminal, calcium comes into the neuron, and that's what triggers the release of acetylcholine. And so if you have antibodies to these calcium channels, then calcium won't come into the nerve terminal, and you won't have acetylcholine release. And so if you understand that, then it's easy to understand that the diagnostic test for LEMS is measurement of so-called VGCC antibodies, which stands for voltage-gated calcium channel antibodies, the hallmark of Lambert-Eaton myasthenic syndrome. Okay, so we touched on this earlier, but patients with LEMS present very differently from patients with myasthenia gravis. Patients with LEMS usually do not present with eye complaints or bulbar weakness. Instead, they present with symmetric proximal muscle weakness. This means weakness of the muscles involving the shoulders and the hips. So this is going to make it difficult to walk or rise from a chair. It's going to make it difficult to comb your hair because you have to use your shoulder muscles to lift up your arm. These are all things that are evidence of proximal muscle weakness. The muscle weakness usually has a slow onset, and one thing to be aware of is you can also see this in myositis. So proximal muscle weakness is also a classic symptom of myositis. However, in the Lambert-Eaton myasthenic syndrome, the CK levels are normal because you don't have inflammation of the muscles, and there's also no muscle pain or myalgia in LEMS. So these are key features, especially in board questions, for distinguishing LEMS from myositis. And then lastly, super high yield to know that in LEMS, you will see hyporeflexia, which is the opposite of what you see in myasthenia gravis, where reflexes are usually normal. Because those calcium channels are blocked, when you test reflex arcs, you are going to see a diminished reflex response, and that's hyporeflexia. So in LEMS, you have antibodies that affect the neuromuscular junction, and that causes weakness. But those antibodies also affect nerves that are part of the parasympathetic nervous system. And so as a result, you get autonomic dysfunction. This is a classic feature of LEMS. This is not something you see in myasthenia gravis. The classic complaint is dry mouth from decreased salivation, and that's because parasympathetic neurons cannot depolarize normally and drive the production of saliva. You can also see other evidence of autonomic dysfunction, things like erectile dysfunction in men and things like constipation from decreased GI motility. Another important distinction between LEMS and myasthenia gravis is that muscle use in LEMS improves symptoms. This is the opposite of what we talked about in myasthenia gravis, where you have fatigability. The more you depolarize the nerve terminal, the more presynaptic calcium you bring into the nerve, and this leads to more acetylcholine release. So using muscles over and over is going to lead to improved symptoms in LEMS, the opposite of what you see in myasthenia gravis. I've listed some of the treatments for LEMS here. One of the big ones is to treat or locate the underlying malignancy. If the patient has lung cancer and you remove the lung cancer, that will make the LEMS go away. There's a niche drug who really only has one major indication, and that is the treatment of LEMS. It's called 3,4-diaminopyridine. This drug, through a complex mechanism, enhances acetylcholine release at the neuromuscular junction, and really its only major use is in the treatment of LEMS. And then beyond this, immunosuppression with steroids and other drugs can sometimes be done to try and reduce the immune response and reduce the production of antibodies. Importantly, though, and this is something you should know for your board exams, acetylcholinesterase inhibitors like pyridostigmine usually don't have much effect in LEMS. And that's because in LEMS, you're just not releasing enough acetylcholine into the neuromuscular junction. So even if you block the breakdown of acetylcholine, it doesn't help that much because you simply don't have enough acetylcholine present at the neuromuscular junction to begin with. You can do electromyelography testing or EMG testing to make the diagnosis of LEMS just like you can for myasthenia gravis. EMG testing involves high-frequency repetitive nerve stimulations, and what you will get is something like what's shown here on the slide. So this depicts repetitive nerve stimulations, and you're getting more response at the neuromuscular junction with repetitive stimulation. And remember, this is the opposite of what we saw in myasthenia gravis, where you had fatigability, and therefore you got less response with repetitive stimulations. And then, as I mentioned earlier, you can also diagnose LEMS by measurement of voltage-gated calcium channel antibodies. The specific type of antibodies are called anti-PQ type voltage-gated calcium channel antibodies. You should know this whole name for your board exams in case any piece of it comes up in an answer or question. And so I'll finish this video with the two neuromuscular junction syndromes that you should know, myasthenia gravis and Lambert-Eaton syndrome. All the different features of the two disorders are here and how you can distinguish one from another. And that concludes our module on neuromuscular junction disorders.